Good afternoon to all of you. Uh, Today, we are going to discuss a very important topic in sleep disorders. I'm a neurologist, and a lot of time I see sleep disorders are hidden problem in my patients, and I'm sure a lot of clinicians or physicians would have found the same thing. A lot of time I find patients with headache or let's say poor concentration, and at times patients complain that they are not able to focus properly. So all of them at times have hidden sleep difficulties which are creating these kind of problems. So insomnia, if we talk about insomnia, approximately 80-90% of us at some point of time has faced sleeplessness or insomnia. That's insomnia can be acute or chronic, and it can stay there for a day or few days depending upon a situation, and it may persist for long durations like 3 to 6 months or sometimes even for years. I've seen patients where patients complain that they have not been able to sleep for last 10 years. They're only sleeping for a few hours, and they are not feeling fresh. They are not living up to the expected quality of their life, right? So this is the reason I felt there is a need to spot the sleep disorders in our clinics, because a lot of time managing sleep disorders would help you manage rest of the patient's problem. And suddenly by managing the sleep, you would see that the BP has got corrected, the sugar values has have corrected, the patient is more happier, they are able to contribute more to their life, to their profession, right? And I think I would start straight away to my presentation, understanding sleep disorders. I would like to introduce myself formally. I am Dr. Sweta Singla. I have done my DM in neurology from All India Institute of Medical Sciences, and after that, I have done a fellowship in clinical genetics from Sir Gangaram Hospital. And my interest in sleep disorders started from my neurology training at AIIMS. Initially, I always used to feel that what would sleep lead to, and why is it important that we need to study? But gradually, I understood the importance of sleep in the management of my neurological patients, and I gradually found that even a lot of medicine patients or a lot of patients otherwise also have sleep disorders. Sleep disorders are rampant. We do not have data, and who are the most of sleep deprived people who do not actually get sleep? If we see around us, first of all, I would like to say the doctors, right? There are so many doctors who are unable to get sleep because they are surgeons. They have to get up at night, or they have to attend the emergencies, or medical students and nurses, they have to do night shifts. And apart from nurses and doctors, anybody who's anyways doing night shifts, now we are working 24/7. A lot of uh, work areas or working sectors like banking, and a lot of IT professionals are working, in US time. So a lot of those people are sleep deprived, or they're not having the proper quality of sleep. Again, people who are working in military forces and policemen, they also have extended working hours. Social worker who have to support people at the random times, they have to go and support people in the evenings. Caregivers are the ones, actually here we are referring to the people who are taking care of the elderly people, right? Again, so there are times people have deadlines, like economists or CAs or people working in financial sector, and people who were working against a deadline like plant operators or for building constructions. All of them a lot of time are sleep deprived, and the consequences of sleep deprivation or poor quality of sleep is often seen, though ignored by the others, because everybody wants to get their work done. So the enough importance to proper sleep quality and duration is not given. There has been, recently there has been a study wherein basically assessment of which I wanted to assess the sleep quality among medical doctors and the tertiary hospital in semi-rural settings, and almost all the responders were poor sleepers, and they had prolonged working hours, And there was also heightened daytime sleepiness. And at times we all say as physicians that physicians are the most tired out. And I think that is also partly one of the reason that we are not sleeping properly at night, that we feel tired the next morning. Again, data from various countries or nations regarding sleep problems. Sleep is something a lot of people do not give importance to. So again, a lot initially we do not know about initially, so we are thinking it is a global epidemic right now, but we do not know what was happening in the past. So this was a study which was sponsored by WHO, which was done by WHO, and like approximately 8 nations were studied, and there was self-reported questionnaire which was which patients or people have to general population have to fill. And over here you can see the poor quality of sleep in different regions, Asian and African. And over here the worst nations who were afflicted by sleep disorders, at least the perceived uh, poor quality of sleep, was South Africa, Vietnam, and Bangladesh. India was faring better, but again, it all depends upon where this survey, which sort of population was covered. And a lot of times, because I sleep disorders daily, and any patient wherein sleep asking a simple question like, "How was your sleep?" that helps me understand the psychology of the patient, that helps me understand the gravity of the patient. And even then a lot of time patients say that are theek hi so rahe hain. Because they feel that whatever they are doing, it's working for them, it might be 4 hours. So they do not understand the consequences of poor sleep, right? Similarly, again, both poor sleep quality was reported by both men and women, and women were reporting worse poor quality. So again, if we see the sleep in numbers, and this is just a graphic, and if we see the graphic over here, and if we this graphic is actually from the UK article, but then if we and similar uh, data would be the data would be similar for Indian people, but then there are few general things that we need to see over here. So first thing is we need approximately 7 to 8 hours. 9 hours is a little much, but then 7 to 8 hours of sleep is something that we need daily for our normal functioning. Anybody who's sleeping for less than 6 hours, which is the 13% of the general population, there is a 13% higher mortality risk for adults who sleep less than 7 hours. And anybody who's sleeping for less than 7 hours, there are 30% they are more likely to be obese. 30% are more likely to be obese. People working in night shifts has about 25 to 30% higher risk of injury because of poor focus, right? And they are not able to focus on the work. Again, there is something called circadian rhythm, which we'll just discuss after this. And we sleep most sleepiness occurs around 2 p.m. and 2 a.m. And better sleep is the biggest single contributor to better living, right? And going on to the next slide, so this is again has been taken from WHO website, and you can see the sleeplessness or insomnia affecting the DALYs, which is the disability associated lost years of life. So over here we see the red countries are most afflicted with sleep disorders and or insomnia. And basically, if you can see India and the Pakistan region, this area that it is very highly or severely afflicted, right? So general things, we spend about 1/3 of our lives in while sleeping, an average of 3,000 hours of sleep per year, which seems a lot, but then that is required. But again, even after this, most people they do not get enough sleep. And what are the effects of sleep deprivation? Patients have problems with the cardiovascular health. They have difficulty in concentration. They have poor memory. They have emotional instability. They have mood swings, and they are not able to work to their normal self. Again, limited statistics from US. So 50 to 70 millions, 48%. 48 is a huge amount. I mean, huge chunk of people. 48% report snoring. 37.9% report unintentionally falling asleep during the day. So possibly because of obstructive sleep apnea or nighttime fragmentation, sleep fragmentation. 4.7% reported nodding off or falling asleep while driving. So this again is important, because if you are napping, taking a nap, or nodding off or falling asleep while driving, you're prone to accidents, and that would affect not only your life, it would also affect other people's lives, right? So this is very important and needs to be taken care of urgently. Again, this is the same data that we just discussed. And if we talk about insomnia, so insomnia can be related to, again, this is just a distribution of various possible reasons which might be leading to insomnia. We'll also come to this again in short while, but then we'll just complete it over here. So a lot of the insomnia people, again, recognizing insomnia is important, because a lot of these patients would have mental disorder or neuropsychiatric illnesses like depression, anxiety. Approximately 15% have periodic leg movement, and 10% have poor sleep hygiene. And this is a slightly old study, but I'm sure now poor sleep hygiene is playing a bigger role, because a lot of people are on the mobile. After the COVID period, what has happened, everybody has gone on to the screens, and television screen has shifted to the screen in hand. And what has happened at that point, that we feel we'll be lying down on our bed and watching the mobiles at night before going to sleep, because we want to check mail, we want to be socially active, we want to be on WhatsApp, we want to be on Facebook, Instagram, and these sort of engagements actually way of perpetuating. So once you're on the mobile, you stay on the mobile, you say it is 5 minutes, but you do not realize the half an hour or 1 hour has passed. And what is happening because of this, that once you're on the mobile and the screen is directly onto your eyes, your brain is getting the message that probably it is a daytime, so you're pushing off your sleep, right? So this is important, that now probably the poor hygiene has increased, sleep hygiene has increased. And even though it was initially 10%, if we do a study, we'll be able to find that probably this is contributing more. Again, patients using psychoactive substance related abuse, they are also related to, they may also lead to insomnia. Again, medical or neurological conditions, right? Like Parkinson's disease, or any medical conditions, like for example, patient has CAD or heart failure or asthma, they have difficulty in breathing, some people have osteoarthritis and they have knee pain. Again, these all patients also have nighttime awakenings, and these nighttime awakenings gradually create disturbances in the circadian rhythm and may create insomnia in the longer run. Again, this is the sleep apnea prevalence. This was again this is an epidemiological overview, and if we can see that for this is the sleep apnea prevalence. So if we can see the AHI prevalence, disturbed or AHI of more than 5, which is that definition of obstructive sleep apnea, and it has been studied in India by Sharma et al. And Reddy et al. Right. Again, the studies were from mostly from South India, and it was seen approximately 2.1 to 2.5% of the patient had sleep apnea syndrome. Again, prevalence of RLS, if we see again over here, there is one study from Bangalore, Rangarajan et al., and we can see the prevalence was 1.266 or 2.1% of the prevalence was there, right? Again, roughly, again, coming to trying to understand the circadian rhythm. So circa is about, CN is about a day, which is like about a day rhythm, which is around the day, right? So the circadian rhythm actually is a 24-hour cycle wherein there are physiological processes of living beings, including plants, animals, fungi, and cyanobacteria. So again, we need to understand that this definition per se itself includes that the circadian rhythm is existing in all the living beings. It could be amoeba, it could be plants, and it is endogenously generated, is it genetically coded, even though it can be modulated by external cues such as sunlight, again, something like engaging, something as engaging as mobiles, by the temperature. But then it is, there's something called hotspots, and right, your genetic coding. So again, mutations in those areas actually are not viable. If you do have mutation in that area, the living being is not viable to live, right? So circadian जो genes होते हैं, they are approximately in those hotspot zones, right? So basically, if you have mutations in circadian genetic genes, the living being cannot survive. Any living being cannot survive. So just a brief overview of the circadian rhythm. So again, a Nobel was also given to answering how the circadian rhythm is maintained, and it was given in 2017 to the Hall, Rochbush, and Michael W. Young, and they did a lot of work. Historically, it started with 1790, 1729, wherein French astronomer Jean Jacques d'Artois de Marian, he studied mimosa plant, and he saw the leaves were bright in the sun and down in the night. Again, in 1930s, a German biologist Erwin Bunning studied the plant leaf movement over a period of 24.4 years, and they saw that these leaves were drooping even in constant light. So again, it was not light alone. A light was a cue, but it was not light alone that was leading to the circadian rhythm in these patients. Again, in animals, the first of in 1960s, in animal studies, animal like initially it was only found because of the mutation in Drosophila. The Drosophila had arrhythmic circadian rhythm. So again, it was more of at that time they realized it is genetically encoded, and it is despite whether there is a sun or night, this there is some sort of endogenous mechanism which is creating this rhythm. Then there was a scientist by the name of Konpa and Benzer. They found three mutants and abnormal circadian rhythm again in Drosophila. So again, what happened in 1984? The Hall and Rochbash, they postulated the clock gene, which is the period gene or per gene, and they found there is a feedback pathway where the period gene governs its own RNA transcription, so and thus creating a rhythm. And this was followed by a discovery of TIM gene by Young in 1990s, when Dr. Young found that the TIM gene interacts with PER gene to allow its entry into the nucleus, and therein there is a transcriptional translation feedback loop. Again, again coming to the importance of circadian rhythm, and finally we got to know that yes, at various point during the day, right, we are let's say we have BP, there are a number of physiological phenomena happen, and for example, the BP is highest around 6:30 in the evening, the body temperature is highest around 7 p.m. in the evening, the melatonin secretion starts around 9 p.m. in the evening, bowel movements are suppressed at night, and bowel movements are likely at 8:30 in the morning, and the melatonin secretion, it stops by 7:30 in the morning when the light starts coming and hitting us, right? And we are highly alert at around 10 a.m. So again, different times during the day we found different physiological things that were happening. Again, this is the same repetition of the slide, and again, this circadian rhythm does not stay the same when in the young and in the elderly. In the elderly, what happens? The total sleep duration time decreases, and one of the reasons is that the melatonin peak that happens in elderly is much less as compared to the younger age group. So, and if we see the graph, then we can see that the waking time, this is the 24 hours timeline, and if we can see the REM also decreases, it becomes very small as the patients or the people grow. NREM stays approximately the same, even though the stage 3 NREM decreases in the elderly populations. So they are more awake, they are able to sleep for only 5 or 6 hours, less than 6 hours actually. And this is again the hypnogram. So hypnogram is the depiction of sleep in the graphical model, in the graphical way. So we can see this blue portion is the REM, this is the grayish portion is the NREM. So NREM stage 1, then 2, and then 3. Usually now 3 and 4 are the same, and it has been both the stages have been merged. So and we see early adulthood, old age, and we can see as the childhood becomes early adulthood and the early adulthood becomes old age, we can see the REM is less, sleep fragmentation is more, and the time spent in the deep sleep, right? The stage 3 and 4 is very less in the elderly patients. Again, how does this happen? How is the sleep, does the sleep happen? We had a talk before on the neurobiology of sleep. Only few people were interested, but even though it is a little complicated. But if we talk about the major centers of the brain that is responsible for the sleep is thalamus, then brainstem there is an actually ascending cortical activation or reticular active areas, reticular activating system, wherein lies the REMS small wave sleep switch. Then there is something called suprachiasmatic nucleus, which is the prime governor of the circadian clock, and hypothalamus, which regulates the sleep wake switch. And once basically there is a sensory stimulus that is ascending through the brainstem, and the sleep wake switch is switched off, then there is cortical activation and the patient becomes alert. And basically when the sleep wake switch is switched on, there is a kind of disconnection of the spinal cord and the higher cortical centers. Cortical centers might still be alert, but then there would be inhibition of the lower lower pathway, lower neurological pathway or neuraxis, and there would be inhibition of the muscle so that you do not act your dreams, right? Again, this is only a little bit detailed version of the same thing that I had just talked. Again, what are the stages of sleep? So we have NREM sleep and we have REM sleep. We would not be going into the pathophysiology, but we need to understand NREM sleep is the one which is constituting the major part of your sleep, approximately 75%, and REM constitutes approximately 25%. Again, initially the person goes into stage 1, stage stays in stage 2, which is a substantial amount, 45%, and finally he or she moves on to the stage 3. And after about a cycle of 90 minutes, the number of cycles that happen, 5 to 6 cycles happen over a period, over the night, and then the later in the second or third cycle the REM sleep starts. And then REM is the sleep wherein we have dreams, or it is called the rapid eye movements. Our eyes are moving. On EEG or polysomnography, it seems the patient is awake, right? It's because your cortical centers are active. And there is actually a number of things that happen during the REM and NREM sleep, right? So what is REM? So again, it is a slow wave sleep. So in stage 1, the frequency goes, there is alpha dropout. Alpha is like the hertz of the EEG that we see, usually around 12 to 14. So in the stage 1 goes to less than 11. The waveforms become a little dampened. In the stage 2, it becomes further slow, 4 to 7. Again, there's something called vertex sharp waves, which come in the stage 1. Again, in stage 2, there is something called K complexes and sleep spindles. And in the stage, the waves are the slowest, which is less than 4 hertz, right? So again, this is something that we all see on PSG, and we usually see on EEGs also. You're all most welcome. If you at any point of time want me to share the graphs, I'll share with you. Then REM. REM has been a mysterious kind of a sleep. A lot of time, a lot of neuropsychologists have been studying this REM sleep and postulating what our dreams tell. That there is a major purpose we have dreams. Dreams are kind of it's kind of wherein memories, come up, and a lot of time memories merge with each other. At times we are able to find some solutions also, right? At times it is just the repetition of what we have been through. So let us say that you have like thought about one or the other thing during the daytime, and what happens in the night, these two things, for example, the abstractness happen. This is where then the creativity happens actually, right? And two things, they get activated, or during the REM sleep at the same time, and you're dreaming all those things. And even though it's not a reality, it becomes a reality at some point of time for a lot of people because they live in those vivid dreams, right? Again, dream is important. It helps in retention of the memory, it helps in pruning the unnecessary stuff, right? Unnecessary thing, that what did we eat if we have not eaten anything special. So all of that information gets pruned, right? So again, this kind of information what was needed stays, it gets consolidated, the memory gets consolidated. And many a times, but then again, it serves a limited purpose, because if you have too much of them, you'll wake up, as if you've done a lot of work, mental work, and you get up tired, right? So again, REM and non NREM, so basically non-REM. So they are different, and they have different characteristics, and they look different on the EEG or the PSG. Again, NREM is a slow EEG, whereas EEG is similar to awake person in the REMs. That is why it is called the paradoxical sleep. And in NREM, we still have some sort of muscular activity. Dreaming is rare. Patients can be easily awakened. People can be easily awakened, approximately 75 to 80% of time. Again, there are no movements. Otherwise, we'll start connecting our dreams, right? This is what happens in RBD, REM behavior disorders, which usually are seen in Parkinson's disease and other Parkinsonian syndromes. And a lot of time, a basic occasional RBD or something like dream enactment happens, and we might find one or the other relative in our near and dear ones who was like standing up and flying a kite, or just going out towards the door. So if you look around, you'll find a lot of people. So it is not that rare. It is not reported, but it is not that rare. Again, no movement is there. This is to inhibit your movements or enactment of this dream. Arousal is hard, and approximately only 20% of the time over the night is spent in the REM. Again, what happens when we do not have this normal sleep pattern, or if we do not have, if we have smaller amount of sleep, if we have primary insomnia, if we have poor quality of sleep, right? So what happens? Actually, there is a activation of the sympathetic system, and the vagal control is a lot of times lost. This leads to inflammatory processes activation, which leads to increase in CRP, increase in interleukin 6, and there is cellular expression of cytokines like IL-6 and TNF alpha is also activated. There is activation of inflammatory markers like NFKB, and all of this inflammation, if you're not sleeping well, inflammatory pathways get activated. And once the inflammatory pathways get activated, we can think of all the consequences that can lead to further on the cardiovascular diseases like cardiac CAD, MI, myocardial infarction, stroke. These are the common ones. Again, a lot of times demographic and behavioral moderators and mediators affect all of these. There can be a particular age group, gender can also affect these kind of inflammatory, consequences. Again, depression might result, and depression can also be the problem. Again, there is a bidirectional relationship of insomnia and depression. So depressed people sleep less at times, and less sleeps further on increases their neuropsychiatric symptoms. Again, obesity. Obesity is a common problem, and wherein a lot of neuropsychiatric illnesses are also related. Apart from that, obstructive sleep apnea in obese people can also lead to sleep fragmentation. And sleep fragmentation in these group of patients, that further on leads to poor, let's say, poor functioning through the day, and also it can lead to insomnia in the longer run. Alcohol consumption, so if your patient has not taken alcohol, they would not be able to sleep. Cigarette smoking, and a lot of time people are taking stimulants like Red Bull or other stimulating drinks. These are commonly available and very cheaply available. So a lot of times students take these kind of drinks, right? And they further on develop insomnia or other sleep disorders, something like delayed phase sleep cycle, etc. Again, this is just the potential mechanism. So there is endothelial dysfunction. The reactive oxygen species are activated, which leads to thrombosis. Again, cardiovascular diseases increase in these patients. And apart from this, I mean, I would like to say a lot of times, there was a case I would just like to, recapitulate over here. 70-year-old gentleman, and he presented to us in the emergency, and basically he had some repeated shakings, and wherein he was not responsive. MRI was normal, EEG was normal. His BP was sky high, 190 systolic, 200 systolic. And I mean, apart from being, despite being on four medicines, he was unable to, we were unable to control the blood pressures. And he still was having those recurrent shivering or some abnormal movement episodes. And we found that the patient was not sleeping well. There was an associated neuropsychiatric problem like depression in that patient. We corrected the depression, gave a little bit of anxiolytic, told him to follow the proper sleep hygiene. And after about a week or 2 weeks, the patient was doing very well. His BP, which required uh, at least four medicines, and even then it was not controlled, it got controlled only on two medicines. Patient has been doing well. I have kept that patient on a minimal dose of SSRI. And therein at times the patient teaches you a lot. And the patient teaches you that if you correct the simple problem or the root cause of, let's say, the refractory hypertension, then you're able to correct that, avoid the domino effect that happens, right? So again, the effect of sleep deprivation again can also be not only on the blood pressure, it can also be on your memory. There can be memory lapses. Again, it can be at times, occasionally, may lead to hallucinations. There is impaired immune system. There is a higher risk of diabetes because inflammation, as we saw, it increases during these times, right? And if we talk about other, effect of increased sympathetic activity in these patients, there is heart rate variability, risk of heart disease, and there might be tremors, there might be body aches, and apart from that, there is a risk of obesity, and patients' general thermal homeostasis is also deranged. Again, clinical presentations may vary. Some people would say they feel tired, they can complain of chronic fatigue, tiredness, or sleepiness during the day. There is a proper questionnaire, Epworth sleepiness scale during the day. And over there, we have to actually see, like, during which activities the patients feel sleep. For example, if we are not talking to the patient at that time, does he feel asleep? Or if he's watching television, or if he's, in some public place and nobody is talking to him, there he feels asleep. Or on during driving, does he feel asleep? So again, this I mean, the patients might come up with a lot of these kind of complaints. Again, difficulty in concentrating at work or in school, poor academic performance, poor work performance, and usually delayed response to stimuli or events, difficulty in remembering things, having that frequent urge to take naps during the day, and snoring or ceasing to breathe. So what happens in apnea, sleep apnea syndrome? There is a crescendo, there is a snoring that happens, and there is a crescendo. At the top of the crescendo, where the snoring is highest, there is a break, right, in the breathing. It's more like, and then there's a sudden break. And this, after sudden break, the patient suddenly gets up for a fraction of a second in a very, haphazard way, and then goes back to sleep, right? So this happens multiple times during the night, right? And this leads to sleep fragmentation. So every time arousal happens, arousal means the wakefulness happens, the patient is not patient is coming from the stage 3 and going to the wakefulness, and the sleep cycle starts again. So again, the slow wave sleep is not happening in that patient. And slow wave sleep is important for your body's for recovery from the normal day. Then coming to sleep related disorders. So there can be, we can divide it into a number of types. There can be increased or decreased sleep, which is the duration, whether it is refreshing or not. What about the dreams? Are they coming? Are they excessive, or are they not coming at all? Then what is the circadian? And there we can also divide as per the circadian rhythm abnormalities, and which part of the sleep or the stage of the sleep are the disorders coming. Is it the NREM or is the REM? Then there are associated movements during the sleep, which can be before the sleep and during the sleep. Before the sleep is RLS, and after the sleep is PLMS. Then sleep related breathing disorder, which can be simply SRBD or unclassified, or they can be proper OSOS, obstructive sleep apnea syndrome. So coming to what is the dysomnia and parasomnia? Dysomnia means difficulty in getting enough sleep, and it can be as per that the timing is not proper. The patient is not getting enough sleep in the sense that duration of the sleep is less or the quality of sleep is less. Apart from this, there is something called parasomnia. Parasomnia means there is abnormal behavioral and physiological events during the sleep, which can be sleepwalking, sleep eating, sleep talking, right? And again, nightmares would also come in the category of parasomnia. Again, sleep wake disorders, we have a proper classification, DSM-5, and therein the different codes have been given to sleep disorders. And again, insomnia, hypersomnolescence, narcolepsy is another one, where is which are without doubt hypocretin deficiency or mutation. So again, obstructive sleep apnea or hypopnea syndrome, central sleep apnea, then sleep related hypoventilation, circadian rhythm sleep wake disorder, disorders of arousals, nightmares, uh, rapid eye movement sleep RBD or REM RBD is rapid eye movement sleep behavior disorder, RLS, and substance related sleep disorder. Again, dysomnia, if we talk about the duration of the sleep, that can be insomnia or sleeplessness, hypersomnia, increased sleep. Circadian rhythm disorders also come under the category of dysomnias. So circadian rhythm can be early phase or delayed phase. Delayed phase means they are sleeping at late at night and getting up late in the evening, or early phase is like they're sleeping early in the evening and getting up early in the morning, and which is beyond the normal sleep hours, like for which is usual sleep hours. Again, sleep related breathing disorders, which we talk about, OSAs, and sleep related movement disorders, which were the PLMS and RLS. Again, primary insomnia, it can be for a few days, which can be because of some adjustment issues. For example, somebody had exams, or somebody had some tragedy at home, and they are under some stress or deadline. They have to report give, just give some thesis. A lot of time you'll find medical students or research scholars, writing their thesis and then having insomnia for a number of days. Again, somebody who has a deadline, like somebody like who's a CA, and they are unable to sleep for that duration. So again, insomnia, those type of insomnias are short term, and they are acute insomnias, and they usually recover once the period is over. Then there is something called psychophysiological, which usually last about 1 to 3 months. Again, these can start with a stressful time and which can persist. And again, a lot of time what happens in these patients, that initially they are insomniac, right, because of a problem. After that, the circadian rhythm gets disturbed, and after that what happens, that patient says that now my stress is over, why can't I sleep? Let the sleep come, because I have to work the next day. So some sort of sleep anxiety creeps in, and this sleep anxiety creates a question in the mind or apprehension in the mind whether I'll be able to sleep today or not, right? So this apprehension leads on to further on insomnia. So this insomnia, that let me get some good sleep, let me get some good sleep. So this goes on and on. This creates a paradoxical stress, right? And therein this insomnia gets strengthened, becomes more chronic. And and even when the stressful period was few years back, I've seen people complaining about insomnia for years and years because they have not been able to get rid of their sleep anxiety. And once you are on to the sleeping medicines, which are usually tranquilizers or sedatives or hypnotics, then at times if you're taking one tablet, right, ours is a country where you can get poisoned by the chemist, even though the government has become more strict about giving the sedative medicines as per today. But then a lot of people get easy access to alprazolam or clonazepam, and what happens for first week or 10 days, they just want one tablet to relax, but then a sort of dependency comes, and they want two, and after that even more. So I've seen taking people taking up to 10 grams of alprazolam to sleep. And what happened when they suddenly wanted to decrease, and they finally realized that, oh, now I am dependent on this medicine to get sleep, and they just wanted to leave the medicine. They had seizures, breakthrough seizures. All of these are kind of anti-epileptic also, and if you suddenly stop them, there can be a possibility of seizures, right? Then there is something called paradoxical, right? And in these paradoxical insomnias, people are adjusted. There is no daytime impairment, but at night they are not able to sleep. And at many a times there is an idiopathic insomnia, which can also be familial, or it can also be because of some underlying disorders, neurodegenerative disorder. There's something called familial fetal insomnia, in which there are mutations, which we are not going into now, but then we'll be able to discuss in case somebody is interested in some particular day. So again, what cause insomnia? Just a graphic. So it could be the lifestyle, it could be the mental disorder, it could be some pain, it could be irregular sleep schedules, stress, medications, neurological disorders. Again, age can create this. Mobiles, yes, screens, and at times pregnant women. Pregnant women can also have insomnia because of RLS. So restless leg syndrome is another thing which can actually lead to insomnia. It may occur only initially, when the patient goes to the sleep, but then it has a way of amplifying if given the right kind of environment, which can be actually anemia, hypocalcemia, neuropathy, uncontrolled diabetes. All of these things, or some at times some drugs also can lead to RLS, right? So again, all of these things can lead to chronic insomnias. So again, this cartoon just wants to depict that, yes, if you don't lie on the bed, you know, worrying about your insomnia, you'll be able to sleep, right? So a sleep anxiety many a times needs to be targeted while we are taking care of these patients. Then there is secondary insomnia. Again, this is usually the thing that we see in our practice. And again, inadequate sleep hygiene is very common nowadays. And again, this needs to be targeted. People need to be explained that they, at the time of sleeping, they need to calm down. They need to create an atmosphere of, calmness, or sense of calmness around them. So it should be dim light, it should be relaxing atmosphere. It should, the mind should feel that, okay, I have done my day's work, and now there is nothing much more to achieve for the day, and rest of the things would need to be handled tomorrow. But actually most of us are working through the day, through the night, checking emails, doing whatever, moving forward in life. So all those things. So again, poor sleep hygiene is one of the most common reasons. It can be secondary to medical disorders, substance abuse, and at times it might not be associated with all of these. There's something called behavioral insomnia of childhood. And again, there can be different types. Limit setting type, wherein the child needs to be told that there is a set limit, you have to go back to sleep, and get up at the right time. Then sleep onset association type, wherein a lot of time conditioning before the sleep. What type of conditioning the child has? A lot of time you create an conditioning to the sleep. I mean, I remember my cousins sleeping with the chitrahar on, and when they were kids. And if you see, a lot of times people play lullaby or just give a soft toy to the child. So what kind of conditioning you have already set? And if you do not have that setting, the child would not be able to sleep. Then there is mixed or unspecified type, wherein we do not find all these reasons. Then there is coming to the next. So insomnia we can discuss further on if anybody has some questions. Then there is something called hypersomnia. Hypersomnia means more than 9 hours of sleep. Again, a lot of these patients might have narcolepsy with or without cataplexy, which again there is a strict definition wherein the patients have sleep attacks. They sleep for a few minutes and they get up fresh suddenly during the day, even when they're working. Then these can be associated with sleep paralysis, and while they are sleeping and suddenly feel they can't move the body, right? Again, what is more in the disorder of narcolepsy is hypnagogic and hypnopompic hallucinations. There is vivid visual phenomena that happen, right? Again, it is not that uncommon. It can have an organic basis, it can also have a familial or genetic basis. Then there is something called recurrent hypersomnia or periodic hypersomnia. uh, so again, you would see some patients wherein they have I mean, they would have few normal days, and after those few normal days, you will feel that they'll sleep for 2 hours or 2 days at a stretch. Right? They'll get up and then take some food, they'll go back to sleep. Right? So this can be associated with genetic syndromes called Clan Levin syndrome, and which obesity is also there. And then it can also be associated with menstrual related hypersomnia. Then there is something called idiopathic insomnia and behavior induced insufficient sleep syndrome, and hypersomnia because of some medical condition or because of the medications. Then sleep disorders in which there is circadian rhythm abnormalities. So again, this can be delayed phase or advanced phase or early phase. So delayed phase means they're sleeping, they're studying at night, sleeping at 3 a.m. in the morning or 4 a.m. in the morning, and then they're getting up, let's say around 3 a.m. they're sleeping, or 4 a.m. and they're sleeping, getting up around 1 p.m. in the afternoon. So they're completing their sleep duration, but they're completing at the wrong time. So there is some, this is again a lot of time is has to be is there is association with cues and what they are doing through the day, what they're doing in the evening, right? Similarly, advanced phase sleep cycle is there, and a lot of time people who have jet lags, or let's say they change the timelines. They're in India from IST, that they go to UK, or they you go to US, and especially US because it's kind of 11 to 12 hours apart. So again, therein they may have faced similar issues. There are a few cases wherein we have seen that people or children or students with who have been taking energy drinks or a lot of caffeine, they can have these kind of problems. Free running type, there is no cycle, right? The jet lag type means your timeline has changed, and jet lag has occurred because of the jet lag. Shift worker is important. Shift worker because there are different types of shift workers. Again, a lot of time, if you see the nurses, like they'll say we do one night shift in a week, right? Or if they'll say that there are few other professions wherein they say that we have to do 4 nights at the same time. They'll do those 4 nights at one particular time, night shift, and then it would be rest of the time day shifts would be there, right? So if you it takes about 1 or 2 days to adjust to a new sleep cycle. So somebody who's actually working in a shift working job, like a nurse or a policeman or somebody in the IT profession, so if they do one uh, night shift in a week, so their sleep is more likely to get affected because you're barely adjusting, and then you're going into the next shift, and then finally you're going back to the normal shift, right? So your sleep cycle does not understand what you're doing. Your circadian rhythm goes chaotic, right? So again, somebody who's actually doing 4 nights in a row, and 4 night shifts in a row, and then going back to the next apna normal sleeping schedule, that is still much better because you are able to adjust back to the normal sleep cycle. Again, sleep related breathing disorder, which can be primary central hyper sleep apnea, which can be because of high altitude periodic breathing, which can be obstructive sleep apnea, either adult or pediatric, and then idiopathic sleep related non-obstructive alveolar hypoventilation. Then there is something called congenital central alveolar hypoventilation syndrome. Grossly or broadly, what happens, if you can see, there are two diagrams, one on the left and one on the right. So over here, you can see that there is tongue, there is palate, right? There is epiglottis, and you can see there is a airway, oropharyngeal and nasopharyngeal. And epiglottis in the first diagram is not touching the posterior pharyngeal wall. Whereas what happens during, and there are passage, airway is, air is free, has a free air passage. Again, in obstructive sleep apnea, which can be because of a bigger tongue, thicker neck, right? Smaller jaw, right? So again, the airway collapses, and it collapses up to an extent, and all of us, right? Because the muscle tone goes down. So once the airway collapses, in a normal person, the tongue is not hitting the posterior pharyngeal wall. But if you see the second diagram, the tongue, the palate, it all is touching the posterior pharyngeal wall, and the passage, the free flow passage to the air from the nasopharynx, it gets obstructive. So what happens? The patient opens the mouth, and then there is snoring. Snoring is only the fluttering of the soft palate, right? And at times when the snoring is at the crescendo, the obstruction is complete, the airway passage stops, and the patient suffers hypoxia for those few seconds, and that leads to hypoxia in that particular patient. Hypoxia means oxygen levels went down, and the brain is not getting oxygen for few seconds, and for those few seconds the brain goes into arousal or wakefulness. So this happens again and again. Up to 5 times in an hour can be considered as normal. Anything which is more than 5 times AHI, apnea hypopnea index of more than 5 in the polysomnography is diagnostic of OSAS. So again, what happens? We give BiPAP or CPAP, and these machines, they only open the passages, right? They only open the airway passages by pressure. It's a positive pressure airway, right? Then again, OSA is characterized by snoring apneic spells that we have already discussed, and it is associated with hypertension, type 2 diabetes, atherosclerosis, endothelial dysfunction, myocardial infarction, and cardiovascular diseases or CVA, cerebrovascular accidents. And depression also happens in these patients. A lot of time these patients have poor self-esteem, cognitive impairment, poor focus, and inattentiveness. So this all happens in OSA. Parasomnia, disturbances and arousal and sleep stage uh, transition that intrude into the sleep process. So again, parasomnias can be NREM and REM. So again, nightmares is a sort of parasomnia which occurs in REM. Frightening dreams occur, interrupt the sleep and interfere with the daily functioning. Patient readily awakens from the dream, has detailed recall, and rapidly becomes oriented and alert. These are common in children. As they grow, these nightmares disappear, and only 5 to 10% of the adults they may persist. Sleep terrors are the NREM one. These are slightly different from the nightmares. They have the children, again, children are much more commonly affected, even though it is less common than nightmares. They wake up with intense fear, panicky scream. There is autonomic arousal, heartbeat is racing, breathing is more, they are sweating, they are unresponsive to others to, comfort themselves and wake themselves, and abruptly awake from sleep. They have amnesia for the episode and they do not have any dream recall. So these, anyways, are not occurring in the dream phase, right? So again, antidepressants, benzodiazepines, and scheduled awakenings. These are the primary ways of management of sleep terrors. Then something called somnambulism. Somnambulism is that the patient, it happens during NREM, they do not know that they have been walking, right? They rise, get up from the bed, walk about, that blank staring face, and they're unresponsive. Again, it is an NREM parasomnia, so they would not awake again, on the moment, on the spot. People would have to make an effort to wake them up. They would be amnesic for the episode. There would be short period of confusion and disorientation. Again, usually happens in childhood. Again, by teenager, they usually grow up, right? And these do not trouble them for long. But during the childhood, it can be very problematic for the parents. They actually have to be very vigilant so that they don't actually go out of the home, right? They actually can go and take a bath. And there was a patient who actually jumped from the veranda, and fortunately the veranda, after the veranda there was a basic some flat area where he jumped, but otherwise that could have led to some accident. So patients have to be very vigilant, and parents have to be very vigilant, and again they have to see again if they need some medicines to keep them sedated during the day. So sedatives and hypnotic drugs can help you in those patients. Again, something called sleep talking, these are usually harmless. Bruxism, again, teeth grinding, can be associated with anxieties or poor dentition. Poor dentition means poor bite. Then nocturnal eating syndrome, right? Again, these can be, patients just need to relax, do some meditation before sleeping, that helps, and create a proper circadian rhythm. These are usually, like patients usually grow up. Then something called sleep related movement disorder, RLS, PLMS, periodic leg movement, sleep related leg cramps, and bruxism. These all come under the sleep related movement disorder. RLS is the most common. Again, cultural connotation can be, a lot of times you see in village people putting alta on their feet, or some elderly lady telling others ki mera pav daba do, just compress my legs, I cannot go to sleep if somebody has not pressed my legs, or some people would say just sit on my leg, right? So at times these are the common things in which RLS present in our country, right? Again, so we have already discussed what are the major sleep disorders type, and uh, understanding the major sleep disorder types in the history helps us understanding which kind of evaluation of patient needs to be done, which kind of evaluation or investigation needs to be done for these patients, right? And so history is the prime thing. Asking that the question, how is your sleep? What is the duration? What is the your bedtime? What is the sleep latency? What is your wake up time? What is the duration? How many times you're getting up at night? These are the things that you need to ask. Again, for clinical examination, obviously, if the patient is obese, you need to take the weight, the BMI, chest or the girth, abdominal girth needs to be taken care of. Oral cavity or nasopharynx needs to be examined, right? Especially for oral cavity, if there is crowding, usually a Mallampati classification, which anesthesia people also use to assess the possibility of tracheostomy जब करते हैं, then and putting endotracheal GT tube, that is the same classification for oral cavity crowding that we follow. And then nasopharynx, so ruling out any DNS or ruling out any sinusitis, all of those things should be looked into. Again, this is the Mallampati classification. So you can see again, this is class 1, 2. You can see the uvula. 3, the uvula is obliterated. And I mean, the 4, nothing is visible. Palate and the tongue is visible, right? Just ask the patient to open the mouth. And if you can see, then the first picture, DNS can also, proper problem in the nasopharynx can also lead to OSAS. That also needs to be corrected. Again, problem needs to be identified before embarking on the management, right? Again, these are the sleep diaries. You ask the patient to maintain sleep diaries, assess their sleep quality, put those sleep quality assessment, PSQI, Petersburg sleep quality assessment quality index. Again, there is something called Epworth sleepiness scale. These scales help us to actually evaluate the sleep problem intensity, right? And how much correction, and many times we can follow up our patients with these scales, right? Investigation is again, whether we are looking what kind of problem do we have at hand. Is it narcolepsy? Is it RLS? Is it PLMS? Is it OSA? Or is it insomnia? So again, a lot of time we even sleep studies needs to be targeted as per the problem, right? Polysomnography, again, with EEG, because there might be nighttime events which, again, if we do not do the EEG in the polysomnography, we will miss it. With due respects to all the pulmonologists, they do not do EEGs with the polysomnography. But I would say that even they should do the EEG and take help of the neurologist to interpret those isolated events which are happening during the sleep. Again, actigraphy is something that detects the movement during the sleep. Again, multiple sleep latency tests, these are usually during the daytime. 20 minutes sleep is given, and then usually these tests is done to diagnose narcolepsy, in which there is something called SOREMS, which is the sleep onset REMs. So within 5 minutes the patient would go into the REM sleep, whereas normally we saw that patient actually follows a cycle. They go to stage 1, stage 2, stage 3, and then go on to the REM, right? Again, this is just a picture of how the polysomnography has been done, is done. So there are different types of sensors. There is an elastic belt sensors around the chest, again, to see the chest expansion. There are pulse oximeters to detect the hypoxia. There are some electrodes on the limbs to detect the periodic leg movement. Then there is sensor at the nose to look at the airflow. And then there is sensor on the face and the scalp. They measure eye movements and the brain activity. So this is the hypnogram. We saw this hypnogram and we can see the cycles, the stage cycle. Again, different cycles are happening through the sleep. Let's say if the patient is sleeping from 11 p.m. to 7 a.m., then approximately 5 cycles are happening. And again, if you see the portion of the REM in each cycle had increased, and the slow wave sleep kind of decreased, and the REM increased. And this is the actual PSD graph that we usually interpret. Sorry. How do we manage these sleep disorders? So first and the foremost, sleep hygiene needs to be maintained. So going to the bed at the right time, creating a proper sleep ambience, right kind of conditioning. So some conditioning can be there. The people are used to sleeping on their beds. They're used to sleeping with milk. Milk, a warm glass of milk is usually soporific, right? If you take naps, keep them short. WHO issued guidelines last year that 30 minutes, not, I mean, naps should be limited to 30 minutes. Any nap during the daytime should not exceed more than 30 minutes. It again hampers your nighttime sleep and is not good for you in the longer run. Exercise should be done regularly, physical activity, but heavy exercises should be kept for the morning, and the low intensity exercises like strolling in the walk or strolling or a little bit of yoga and deep breathing, especially the anulom vilom, right, the slow deep breathing types, they can be done for the evening. Then developing an attitude to wind down. So wind down means relaxing before the sleep, telling yourself that everything that has happened, finding out what has happened nice good during the daytime, and everything that has happened, like we just give it a closure. So winding down, relaxing not in front of the screen though, but then relaxing in a positive, relaxing manner, calming down, and keeping the bedroom a relaxing place. You should avoid putting televisions over there and paying bills and reading emails and getting stress at night. Usually, if it can be avoided, you should avoid it, and go to bed during the dark, in a dark quiet room. It should not be hot, it should not be cold, it should be very comfortable temperature. And if you are sleepy, then only go to bed. If you're not sleepy, and then please get out of the bed, do some activity, read a nice positive book, you can listen to some instrumental music, right, do some meditation, those things. Pharmacology, yes, it has a role. Okay, you have to decide which patients to give medicines if they are not able to correct their sleep problems. So then you have to give medicines. Again, recognize what is the primary issue. Therein, your choice of medicine would be affected, right? So whether we need to give a benzodiazepine, which usually should be kept for a short duration, or sedatives, antihistaminics, melatonin, and its agonists are usually, they do not have any potential for addiction. Antidepressants with in patients, wherein uh, there is associated neuropsychiatric illnesses. Now, lamborexant has come, right? It is available by the name of Devico. So, yes, it has good results. This is the orexin receptor antagonist, especially in patients with primary insomnia. Then stimulants like modafinil, especially for patients who have excessive sleepiness. Modafinil, armodafinil, and coffee can be given in the morning. So otherwise, you just tell them to go into the bright light, sunny light, right? Then there are something sleep gadgets that we need to understand. The sleep watches who tells us about the efficiency. There are bruxism ke liye, there are dental implants that help you prevent the grinding of the tooth. Again, for OSA, especially wherein there is some DNS, there are nasal opening gadgets, right? Small gadgets, nares are there. Then for OSA, the CPAP and BiPAP machines are there. And finally, I mean, you have to recognize what is the primary thing that is creating a problem. Then only you have to decide on treatment. And I think if you're sleeping well, if you've had a restful night, and so this is the difference between the despair and hope. You become more hopeful, want to look up to the next day, and you're able to, perform your